Good evening, friends. IDA Malabar branch is pleased to welcome all to the IDEA Kerala State WDC webinar on women and thyroid. We welcome our officials, IDA Kerala State Honorary Secretary Dr. Deepu Jacob Matthew, a CD Chairman Dr. Faisal CP, WDC representatives Dr. Millie James, Dr. Priya Rajendran onto the virtual dais. We also proudly welcome our faculty for the evening, Dr. P.V. Pradeep, consultant endocrine surgeon from Calicut. Hearty welcome, sir, to the virtual dais. Also welcoming to this platform, IDA Malabar branch president, Dr. Shyjus P, branch secretary, Dr. Navjeevan, and branch CD convener, Dr. Unnikrishnan. For the inaugural address, I welcome IDA Kerala State Branch Honorary Secretary, Dr. Deepu Matthew. Over to you, sir.
Good evening, respected faculty, Dr. Pradeep, and President of Malabar, Dr. Shyjus, WDC leaders, and of course, IDA vibrant leaders who have been on a roll over the past months, conducting program after program. Your programs have all been unique and they hold a special place in the programs that IDEA Kerala State has been seeing over the months. Keep up the good work. I'm sure that such programs will be useful to all who are involved, and especially programs like this one regarding to the general health of dentists, especially ladies of IDEA Kerala State. So without much ado and not lengthening the this one, I'm sorry, I'm traveling. I've just reached home. That's why my video is showing a different this thing. So sorry for the inconvenience caused, and wishing all participants happy listening, and taking the liberty to thank Dr. Pradeep for being graciously helping to educate us more with regard to thyroid and its issues. Thank you, and officially inaugurating this event for today.
Thank you, sir. Thank you, Deepu, sir, for inaugurating the session. Over to IDA Malabar branch president, Dr. Shyjus P, for a few words.
Respected State President, State Secretary, Dr. Deepu, our faculty, Dr. Pradeep, a warm good evening to all. നമുക്ക് വെബിനാർ കണ്ടമാനമായി 36th ആണ് നമ്മുടെ വെബിനാർ. കണ്ടമാനം വെബിനാർ നിർത്തി എല്ലാം ദീപു സാർ പറഞ്ഞ പോലെ എല്ലാം യൂണീക്ക് ആയിട്ടുള്ള സബ്ജക്ട്സ് ആണ് നമ്മൾ തിരഞ്ഞെടുത്തത്. അതിന് സ്പെഷ്യൽ കൺഗ്രാറ്റുലേഷൻസ് അവർ WDC ടീം. അവർ നല്ല ഊർജ്ജസ്വലമായിട്ട് മുന്നോട്ട് പോകുന്നു. നമ്മുടെ ഫാക്കൽറ്റിനെ പറ്റി പറയുകയാണെങ്കിൽ തന്നെ നമ്മുടെ കഴിഞ്ഞ മുമ്പത്തെ വർഷത്തെ നമ്മുടെ CDHന്റെ ഹസ്ബൻഡാണ് പ്രദീപ് സാർ. പ്രദീപ് സാർ ഞാൻ ഒരു ദിവസം പരിചയപ്പെട്ടു, 2 വർഷം പ്രാവശ്യം ഞാൻ അടിപൊളിച്ച് പരിചയപ്പെട്ടു, ഓർക്കണമെന്ന് അറിയില്ല. ഏതായാലും എല്ലാവിധ ഭാവങ്ങളും അർപ്പിക്കുന്നു. മെമ്പേഴ്സ് കയറിക്കൊണ്ടിരിക്കുന്നുള്ളൂ. ഏതായാലും പരിപാടി നല്ല ഗംഭീരമായിട്ട് ആശംസിച്ചുകൊണ്ടെന്ന് നിർത്തുന്നു. താങ്ക് യു.
Thank you, Shyjus, sir. It is now time for introducing our esteemed faculty to the gathering. Dr. P.V. Pradeep, sir is the first person to obtain MCH in endocrine surgery from South India. Sir belongs to the 31st batch MBBS of Government Medical College, Kozhikode. He postgraduated in general surgery from the same college. In 2005, sir became a diplomate of the National Board, and he also received MRCS Edinburgh. He is the recipient of FACS in 2014, FRCS Glasgow in 2016, FRCS England in 2020. Sir has previously worked as general surgeon after his MS at Vadagara, and has served as a consultant general surgeon into several hospitals at Kozhikode, Amrita Institute of Medical Science during the period 1997 to 2005. Sir worked as endocrine surgeon at Sanjay Gandhi Postgraduate Institute, Lucknow from 2005 to 2007. Sir has also worked at Nellore from 2008 to 2013. Since 2013, Sir is a senior consultant in the Department of Endocrine Surgery at Baby Memorial Hospital, Kozhikode. Sir operates only endocrine surgery cases. He has more than 60 publications in the field of endocrine surgery and also includes several book chapters. and nearly 600 citations in scientific literature. He is the recipient of several grants, awards, and serves as a reviewer to several national and international journals. His wife, we proudly announce his wife is a WDC member. She is a former IDA National CDH Award winner, Dr. Danya Muralidharan. They have two sons, Advait and Aniket. It is with great pride that we welcome Dr. P.V. Pradeep sir to deliver his talk on women and thyroid. Thank you, sir. Over to you for the session.
Thank you, Dr. Samira, for the introduction.
Thank you, sir.
At the outset, I should thank the IDA office bearers for giving this opportunity to share some views on thyroid with you. I would like to thank the IDA office bearers, Dr. Deepu, Dr. Millie, Dr. Priya Rajan, Dr. Joseph Casey, and also the IDA Malabar office bearers, the President, Dr. Shaju, Dr. Navjeev Raj, and other IDA Women's Council members of Malabar branch, Dr. Samira. First of all, let me thank you for this opportunity to discuss with you on a very important topic related to women's health. Now, I selected this topic, women thyroid, because these two are very closely related, because most of the diseases of thyroid are affecting women. Can you see the screen?
Yes, sir. Can be
Okay.
seen. Yes, sir.
Now, you may be thinking why this is so, why thyroid diseases are common in women. As you know, the bulk of thyroid diseases are autoimmune diseases, and autoimmune diseases are common in women. It is found that the immunity related genes are usually located on the X chromosome. And as you know, women have two X chromosomes, and therefore there is double expression of these genetic material in them. So it is, in a way, it is good to them, but in a way there is an issue there. It is advantageous because the immunity related genes protect them from common infectious diseases. That's why infectious diseases are more common in men when compared to women. But they have more problems with autoimmune diseases like SLE, arthritis, and thyroid is one of those autoimmune diseases. The most common thyroid problem is hypothyroidism, and hypothyroidism is mostly autoimmune nature. That is why women are more affected with thyroid diseases. If you look at the thyroid gland, it's an endocrine organ situated on the anterior aspect of your neck. It's a small gland, about 25 grams, but it affects the function of almost every other systems of your body, be it the nervous system, the musculoskeletal system, the cardiovascular system, or the reproductive system. Everything gets affected by the thyroid gland. Its function is to secrete two hormones, that is T4 and T3. But when you look at thyroid functions, very often you will see something like mentioned as TSH, thyroid stimulating hormone. The thyroid stimulating hormone is actually secreted from the pituitary, which in turn controls the thyroid gland. So these are the three hormones which you will be checking when you assess the thyroid function, that is T4, T3, and TSH. Now, these are some of the statistics which connect women and thyroid. 1 in 8 women will develop thyroid disease in their lifetime. Hypothyroidism is more common in women. The ratio is 8:1. 15% of all women more than 65 years are hypothyroid. Overt hypothyroidism complicates 3 out of 1,000 pregnancies. If you look at Graves' disease, women are commonly affected in the ratio 7:1. And the other problem with thyroid is appearance of goiter or thyroid nodules. The prevalence there is 5% for women. As far as men are concerned, it's only 1%. And remember, 5 to 15% of the thyroid nodules can be malignant. So they have to be assessed. And that's why thyroid malignancies are also common in women. So the common issues in day-to-day practice affecting the thyroid, which you may confront in your dental practice also, are hypothyroidism, hyperthyroidism, and sometimes goiter. So the goiter can affect any patient, right from a child to an elderly patient. But the thing is that the etiology will be different, that diagnosis will be different. For example, this child, the goiter is because of dyshormonogenesis. Whereas in a middle-aged person, it can be a benign multinodular goiter or it can be a malignancy. Whereas in an elderly patient, it's more likely to be a malignancy. You may also come across these sort of patients when you're doing some dental procedure or when a patient approaches you for a dental procedure. Here you can see that the patient has got protruding eyeballs, which is suggestive of exophthalmos. And exophthalmos, if present bilaterally with the evidence of an enlarged thyroid, then it's because of hyperthyroidism. And this is one of the commonest cause of hyperthyroidism, called as Graves' disease. Here, the diagnosis was written on the face itself. Another patient, have a look at the patient. The patient is looking dull, lethargic. You can see that there is edema around the eyes, and you can see that if you look at the eyebrows, the hair has been lost over there, and her scalp hair, you can see that they are scanty and they are brittle. They are short. All these indicates hypothyroidism. So from the face itself, sometimes you can make the diagnosis whether you are dealing with a hypothyroid patient or a hyperthyroid patient who has come to you for some dental procedure. And very often these patients will not give you a history that they are having a thyroid problem. Now, look at the symptoms of this shows the symptoms of hyperthyroidism. A single symptom is not indicative of the diagnosis. Suppose a patient comes to you with weight loss. Even though weight loss is found in hyperthyroidism, if the patient has only weight loss, it need not be hyperthyroidism. It's usually what we are looking at is a combination of symptoms. So the combination of symptoms can be weight loss associated with increased sweating, or the patient may complain of increased bowel movements, diarrhea. They may give history of menstrual irregularities. Most commonly, it is amenorrhea with hyperthyroidism, or they may tell you about palpitations. So a combination of these symptoms is what we are looking at. We are not looking at one individual symptom. So when a patient has these symptoms, you should look for whether there is any eye sign, that is bulging of the eyeballs, whether the thyroid is enlarged, what is the pulse rate. The pulse rate is more than 100. If there is tachycardia, and also look for fine tremors of the outstretched hands. So these things will indicate that not only the symptoms, but there are signs of hyperthyroidism. Similarly, in a hypothyroid patient, again, I want to tell you that it is not one single symptom. It is a combination of symptoms which tell you whether the patient is hypothyroid or not. The most common symptom will be weight gain, but weight gain alone is not a diagnostic symptom for hypothyroidism. So presence of weight gain, along with that, other symptoms like constipation, menorrhagia, dry skin, joint pains, brittle nails. So a combination of these symptoms will tell you that that particular patient is probably hypothyroid. So what I want to stress here is that you should look for a combination of symptoms rather than a single symptom alone. So this gentleman on one side, you can see that's typical hypothyroid, lethargic with facial puffiness, periorbital edema. The same patient, when the patient gets cured of hypothyroidism, after the treatment, you can see that the difference. Hypothyroidism can also occur in newborns. See here, you see the newborn child. The child is, as per the mother, the child is inactive, reluctant to take feeds. You can see that there is facial puffiness, swelling around the lips, protuberant abdomen, umbilical hernia, and the child is typically constipated. So these are symptoms of hypothyroidism in the newborn. And you see here, when you lift up the child, the hypotonia is very marked. You can just by inspection tell that the child is having hypotonia. In children also, there will be symptoms that they will have growth retardation, mental retardation, and you can see the protruded tongue, puffiness of the face. All these things are indicative of hypothyroidism. So hypothyroidism can occur in any of these age groups. Now, in your practice, when patients approach you for some dental issues and you have to do some intervention, and sometimes what happens is the patient gives you a history that the patient is having a thyroid problem and on treatment, or sometimes you suspect that the patient is probably having a thyroid issue. So in that case, what is the appropriate evaluation you should do in a patient with suspected thyroid disease? So one must remember that irrespective of whether the patient is having a thyroid nodule or not, when you suspect a thyroid disease, the basic test is thyroid function test, which includes a minimum of T4 and TSH. And after that, if the patient is having any swelling in the neck, we will have to evaluate further, which usually is done by referral to the concerned specialist who will evaluate further. I will come to the details later on. So for diagnosing thyroid disease, the first step is to take a blood sample. Remember, there are a lot of doubts with the patient and also with doctors regarding when to collect the sample, how to collect the sample, etc. If the patient is not having a dyslipidemia, you can collect the sample at any point of time, at any time of the day. Usually a 5 ml sample is collected from the forearm veins, and you assess the T3, T4 and TSH. There is no need that the patient has to be fasting while you take the sample. But if, as I said earlier, if the patient is having dyslipidemia, you have to take a fasting sample, a morning sample. Otherwise, you can take it any point of time. Then, as I said earlier, if you suspect that the thyroid is enlarged, if you suspect there is a thyroid nodule, then you do the ultrasound examination. Ultrasound examination is done by a 7 to 10 megahertz probe, and we specifically look for certain things which I'll come to in the later part of the presentation. And if there is a nodule, we do the third investigation, what is called as an FNAC, where you use a fine needle to aspirate the material from the most suspicious part of the nodule and then send it to the pathologist to find out what is the nature of the swelling which you are dealing with. Now let us look at the first test what we have done. We have done the thyroid function test. Now how to interpret this thyroid function test? Any physician can do the interpretation. This is how it works. So you have done the thyroid stimulating hormone test. Actually, it is the hormone which is controlling the secretion of thyroid hormones from the thyroid gland. Then you have done the T4, which is the hormone secreted from the gland. Now let us look at what are the possibilities. The possibilities are the TSH can be low, it can be normal, it can be high. Similarly, T4 can be low, normal or high. So what do you get? If the TSH of the patient is normal and the T4 of the patient is normal, then the patient is euthyroid. That is, there is no thyroid dysfunction. Even if the patient has a goiter in the neck, you can proceed with your procedure. You can go ahead with your intervention procedure, dental procedure, whatever it is, you can go ahead. Now, you may get a combination like this. The patient's TSH is high and the T4 is low. So that means the patient is hypothyroid. T4 is low. The secretion from the thyroid hormone is less. So the patient is hypothyroid. Then the other possibility is you may get the TSH as low. Here it is low and the T4 is high. So you are dealing with a hyperthyroid patient. T4 is high. That means thyroid hormone is being secreted in large quantities. So it is a hyperthyroid patient. Sometimes you find that the TSH is low and the T4 is also low. Normally what happens when the T4 is low, that is the thyroid hormone secretion is less, the pituitary gland should stimulate the thyroid gland by increasing the TSH secretion. But here that has not happened. What does it mean? That means the patient's pituitary is also diseased, or rather the pituitary is the defective organ. So you get a secondary hypothyroid where the patient is having a pituitary disease, thyroid is normal. Similarly, you may have a situation where the T4 is high and the TSH is also high. Normally, what do you expect? When the thyroid hormones are high, TSH should be low. Here, the TSH is also high. That means the patient is having a pituitary tumor which is secreting TSH and increasing the T4 of the patient. So similarly, we can have other combination, what is called as subclinical hypothyroid and subclinical hyperthyroid. I'll just describe subclinical hypothyroid. In subclinical hypothyroid, what happens? The patient's T4 is normal, but the TSH is high. That means the patient is in a situation, in a condition of what is called as a compensated hypothyroidism. The patient is hypothyroid, but the pituitary gland is secreting enough of TSH, increased amount of TSH, and that is stimulating the thyroid to produce at least what is required for the patient. So you will find that the T4 is normal and the TSH is high. So you get various combinations like this when you send the patient sample for a TSH as well as T4. So based on that, you decide whether your patient is euthyroid, hypothyroid, hyperthyroid. So if it is a euthyroid patient, there is no contraindication for you. Even if the patient is having a neck swelling, you can go ahead with your procedure. Now, what is the normal values of this TSH and T4? The TSH value, it's important to remember the TSH value. It is 0.3 to 4. And if the TSH is high, it indicates hypothyroidism. If it is very low, below 0.3, it indicates hyperthyroidism. And we also use certain antibodies for the diagnosis. For example, if you have a hypothyroid patient, as I said earlier, hypothyroidism is most commonly due to an autoimmune disease. So these patients will have autoantibodies in the body, in circulation. So you have anti-thyroperoxidase antibodies and anti-thyroglobulin antibodies. These indicates the patient is having an autoimmune disease. And in hyperthyroid individuals, we check the TSH receptor antibodies. So some of your patients may be carrying these reports. And sometimes we get a reference where TPO is high, but thyroid function is normal, asking us whether the patient is fit for a procedure. The TPO or other antibodies have no significance. It's only used for diagnosis. If your patient's thyroid function is normal, you can go ahead with your procedure. Now, coming to the next set of investigations. As I said earlier, if the patient is having a neck swelling, we'll order for a thyroid ultrasound. Now, why an ultrasound is done? An ultrasound is done to find out whether there is a single nodule or multiple nodule, whether it is cystic, whether it is solid, that's all okay. But what is more important is we want to find out whether that particular is malignant or not. It's important to note that there are certain features, a combination of features with which the radiologist can tell you whether that particular thyroid swelling is malignant or not. And that's what, when you, in any case, if you have come across a thyroid ultrasound report, you will see that there will be a report saying that the lobe is of this much size, the nodule is of this much size, and the nodule is having thyroids 2 or thyroids 3. What does it mean? It means the probability of having a malignancy in that particular nodule. Suppose you have a report saying that it is thyroids 5. That means that particular nodule has got more than 85% risk of malignancy. That is why they have said it is thyroids 5. So even if it is a small nodule, if it is thyroids 4B or C or 5 or 6, we'll ask for surgery. Whereas if it is a thyroids 1 to 3, we may not ask for a surgery. So that is the importance of this thyroids classification. Another thing is, if you have a patient with a thyroid nodule and we do a scan and it says that it's a TR3 nodule, and subsequently after 6 months you do another scan and you find that it is TR5, that means the nodule has undergone change and requires a surgical intervention. Then I had mentioned earlier that we do what is called as an FNAC. FNAC is done to find out the nature of the particular swelling which you're dealing with, whether it is benign or malignant. And usually we do it under ultrasound guidance so that we can target the most suspicious part of the nodule so that we don't miss a malignancy in a thyroid nodule, because thyroid nodules have got variegated pathology. Now, when you happen to see a report, FNAC report of a patient with a thyroid nodule, you'll find that it is graded as Bethesda 1 to 6. In Bethesda 1, 2, 3, the chance of malignancy are low. But when it comes to Bethesda 5 and 6, the chance of malignancy is very high. It is in 6, it is about 99%. So based on that, even if the nodule is small, sometimes we tell the patient to undergo a surgery because the Bethesda has been of a higher grade. The other investigation which very often you see with the thyroid patient is nuclear scan. Many of them will be carrying nuclear scans with them. If you go into their detailed history, when you are seeing a dental patient and you happen to get a history of thyroid illness, you may see that they may carry this report. Here you can see there are two images on the lower part, and these images are what is called as a technetium 99 pertechnetate scan. It has been done for two different patients. They have both are hyperthyroid, so they have low TSH and high T4. You can see that in one, the thyroid gland is very well demarcated, whereas the other one, the thyroid gland is not at all seen. That is because you are dealing with two different etiologies here. One is called as Graves' disease, other one is thyroiditis. The treatment is totally different for these two individuals. That is why the nuclear scan becomes very important in our day-to-day practice. Here, there is a patient who's come with a solitary thyroid nodule, and you can see that when we do the technetium scan, only this nodule is seen, the rest of the thyroid is not seen, which means if you just do a hemithyroidectomy for this patient, it will be curative, and the opposite lobe need not be removed, and she will have normal thyroid function because the opposite lobe will produce enough thyroxine later on for the patient. Here you can see in another patient who has got a thyroid nodule. The nodule is on this right side, but when we did the technetium scan, the increased uptake is on the other areas other than this nodule. This means if you remove only this nodule, the patient will still remain hyperthyroid. So to avoid that, we have to do a total thyroidectomy in this patient. So the nuclear scanning will help us, or rather helps us in treatment planning of these patients. Not only diagnosis, but also the surgical treatment planning. So these are the investigations. We do the thyroid function, we do the ultrasound, we do the FNAC, and we also do the nuclear imaging. So it all depends on the indication and the physical findings while examining the patient. Now coming to hormone replacement, we look at the hormone replacement in hypothyroidism as well as hyperthyroidism. The goal of treatment in hypothyroidism is to normalize TSH. Remember this. If you have a patient with a normal TSH, that means the patient can undergo your procedures, dental procedures, because the patient is euthyroid. I'm talking about hypothyroidism. But in a hyperthyroid patient, TSH may not be normal. If the T4 is normal, you can go ahead with your procedure. So in a hyperthyroid patient, normal T4 is needed. In a hypothyroid patient, normal TSH is needed. And how do we correct the hypothyroidism? We replace, we supplement levothyroxine in the dose of about 1.6 microgram per kilogram per day. Usually it amounts to about 75 micrograms for our patients. And then we will monitor the TSH and make it normal. Once it comes to normal, that means that is the correct dose. Very, very often we see that the doctors will reduce the dose when the TSH becomes normal. It is not the right practice. If the TSH is normal, that means the dose of thyroxine what you're giving is normal. But if the TSH gets suppressed, then we will decrease the dose of thyroxine. And there will be dose adjustments also, because in a cardiac patient, you cannot give the full dose in one go. Similarly, in a patient who has got malabsorption, you have to give increased dose. If a patient has got if the patient is obese, you'll have to have increased dose. If the patient is on other drugs, concomitant drugs, then you have to adjust the dose. Similarly, in a pregnant woman, the dose will be always higher than the usual. So about 25% increase has to be provided in a pregnant woman. Now let us look at some important aspects of hypothyroidism in pregnancy. Now I already mentioned about the symptoms in hypothyroidism. Okay. Now, if you look at some of the symptoms of pregnancy and hypothyroidism, they overlap. This can be present in normal pregnancy also without thyroid disease. For example, fatigue, constipation, weight gain, fluid retention, carpal tunnel, All these are present in non-pregnancy also. So that is why sometimes it becomes difficult to diagnose whether that particular lady is having concomitant hypothyroidism or not. Why is it important to detect maternal thyroid function status? Because the maternal thyroid hormones are important, one, in embryogenesis. Second thing, for the fetal brain development. Up to the in the first trimester, the thyroxine is very important. Maternal normal thyroxine levels are very important because after the 12 weeks, the fetal thyroid starts functioning. Another important thing is that the maternal hypothyroidism can cause negative effect on fetal intellectual development and also result in low birth weights and its related complications. So therefore, it is important that the maternal thyroid hormone levels are assessed during pregnancy and keep the levels to 0.3 to 3. That is the normal range. Remember, in a non-pregnant woman, the thyroxine, the TSH target is about 4, up to 4. But in a pregnant woman, the target is about 3, 0.3 to 3. And then we will check it every month, at least every 6 weeks, till the delivery is completed. Generally, when we start treating a hypothyroid patient, the patient will start feeling better in about 2 to 3 weeks. There will be reduction in weight. The facial puffiness will come down and TSH will come down to normal by about the 4th or 5th week of initiating the treatment, if it is the right dose which you have started. Then, so that is about hypothyroidism. Now we'll just briefly look at hyperthyroidism. There are a lot of causes of hyperthyroidism. I will not go into the details of that, but the most important 4 causes I will tell you. One, as I already mentioned, is the presence of Graves' disease. So you will have the ophthalmopathy, you can see the enlarged thyroid, and this is a typical investigation report, technetium scan showing hyperthyroidism. And then the other causes of hyperthyroidism is a toxic multinodular goiter. Here our treatment is usually surgery, whereas in the first case usually it is medical management followed by radioiodine therapy. And also you can have a toxic solitary nodule. Here our treatment will be usually a radioiodine therapy or surgery, because only a hemithyroidectomy has to be done. Then very common problem in our part is Hashimoto's thyroiditis, where you have hashitoxicosis. Initial phase, the patient will be having toxic symptoms. So they have toxicosis, and later on they become hypothyroid. Some may remain euthyroid also. So in these patients, if the thyroid swelling is disfiguring, if there is a cosmetic concern, if you suspect malignancy, which can happen in thyroiditis, then you have to then the patient has to undergo surgery. Most of the patients with hashitoxicosis don't require surgery. So the general principles in management of a patient with hyperthyroidism will be: first, make the patient euthyroid. As I said earlier, euthyroidism is achieved by seeing that the patient's T4 is normal. Whereas in hypothyroidism, I said the TSH has to be normal. Then once the patient has become euthyroid, in certain conditions like Graves' disease, that is enough. You continue antithyroid drugs for about 1.5 to 2 years, and the patient will go in for remission, but they may have relapse. In such condition, or in patients who have got toxic multinodular goiters, then we have to advise definitive management, which includes either a surgery or a radioiodine therapy. That depends on indications. I will not go into the details, but this is the general aspect of management of a patient with hyperthyroidism. Either it is antithyroid drugs. If it in certain group, you'll have to undergo total thyroidectomy or radioiodine therapy. Then let us look at the treatment of thyroid nodules. Thyroid nodules can be benign, non-toxic, can be toxic but benign, and it can be malignant goiters. So depending on that, we will the patient will have to undergo the surgery. Now, you must have seen that many patients would have been, or rather some physicians use thyroxine to decrease the size of the nodule. But that is a very dangerous way of treating thyroid nodules, because when you give thyroxine to a patient with thyroid nodule who is already having a normal thyroid function, they will go into a state of hyperthyroidism or subclinical hyperthyroidism, which can result in osteoporosis, especially postmenopausal women osteoporosis, and also can result in atrial fibrillation and other cardiac events. So routine suppression of benign thyroid nodule with a levothyroxine is not recommended. Then after investigation, suppose you investigate the thyroid nodule, you do the ultrasound, you do the FNAC, you do the thyroid function, everything is normal. Ultrasound says the chance of malignancy is low. FNAC says that there is no malignancy. Then, and if the patient doesn't want a surgery, you can follow up the patient. Follow-up of the patient will be done with periodic ultrasound. Every 6 months, we'll do the ultrasound. Every 6 months, we'll do the thyroid function. Now, there have been studies which have assessed what will happen to the thyroid nodule when you are following up these patients. So, the data have shown that majority of the nodules will increase in size. A few may remain in the same level, whereas about 10 to 13% will undergo a decrease in size. But what is important is none of them disappear. They all remain there. So at some point of time, it will start increasing, and then you may need a surgery, because further data have shown that as the follow-up increases, in this study, at 8 years follow-up, 66% of the nodules grew. And some studies have shown that even at 5 years, about 89% of the nodules have increased in size. So it depends on what is your definition of growth. Because some studies have say that growth will be defined as 50% increase in volume. So they don't consider less than 50% increase as an increase in volume. So you will see that the nodule has not increased as per their data. But in others, where they use 15% cutoff, you see that larger number of nodules have increased in size. So invariably, there is some growth of the nodules in your follow-up. But that doesn't mean that you should not follow up. You should follow up, but you have to periodically, you have to assess the patient with ultrasound and other investigations. Now, what are the indications for surgery in a patient who has come to you with thyroid swelling? One, we look at whether there is any cosmetic concern. Second thing, where your ultrasound and where your FNACs are indeterminate. Like for example, ultrasound says thyroids 4C or thyroids 5, but it just stops short of malignancy. Similarly, if your Bethesda classification says that it is Bethesda 5 or 6, then 5, it has stopped short of malignancy. You will have to advise the patient to undergo surgery for a definitive histopathological diagnosis. If the swelling shows significant growth and follow-up, that is, when you are doing serial ultrasound, if we see that there is a 50% increase in volume, we will say that there is a significant growth. Then we have to ask the patient to undergo surgery. If there is a retrosternal extension, we'll ask them to undergo surgery. In certain patients with hyperthyroidism, we ask them for surgery. If there is, in selected cases of thyroiditis, we ask them for surgery. So these are the indications for surgery. So not all patients will not undergo surgery. If you have a thyroid nodule which is benign, many of them will be on follow-up. And if they undergo procedure, then there are only two procedures, that is either a hemithyroidectomy or a total thyroidectomy. There is nothing called as subtotal thyroidectomy. Some people say that if you do subtotal, you can avoid giving thyroids. That is all. That's a wrong notion, because after the subtotal thyroidectomy, if you follow up these patients over the years, you will find that 90% of them will require supplementation. Plus, they have increased chance of recurrence. So therefore, now we do only total thyroidectomy or hemithyroidectomy. But if the patient is having thyroid cancers, then additionally we will do lymph node dissections, either in the central compartment or in the lateral compartment, or a combination of the central as well as lateral compartment dissections. For surgeries, there can be recurrences, but recurrences, as I said earlier, it happens if there is an inadequate initial surgery. A total thyroidectomy will never produce recurrence unless there is a recurrence in the lymph node or other areas. In the thyroid, if you have removed it completely, there will not be any recurrence. Then one issue pointed out by many is that, especially physicians, is that it will result in a scar in your neck. So they don't send the patients for surgery and they keep it till the end when it becomes unavoidable. But generally speaking, neck incisions heal very well, and women, the Indian women, or rather most of the Indian subcontinent women will have neck skin creases. For example, here in this patient, you can see there are a lot of skin crease, and you enter through one of the skin creases, you hardly see any scar after surgery. That patient has undergone a total thyroidectomy. You can see this patient again. We have gone through a skin crease, so there is no scar in the long-term follow-up. Another patient, again we have used the skin crease. You can see that there is no scar. So it depends on proper incision placement and proper closure techniques. And neck scar generally heal well. Hypertrophic scars may be there in about 2 to 3% of the patients, but that is acceptable when you consider the prevalence of the disease and the number of patients undergoing surgery. Then some patients say that they are not able to raise their voice after surgery. That is because of the injury to this nerve, what is called as the external branch of superior laryngeal nerve. That can be easily protected, provided that particular surgeon is experienced enough to visualize this nerve and protect the nerve. The other problem with thyroid surgery will be loss of voice. Loss of voice happens when the recurrent laryngeal nerve is injured. That usually happens because the surgeon is inexperienced to dissect the nerve, or the nerve may be having branches, or the patient has waited for the goiter to become too large and the nerve anatomy is totally changed, and the surgeon has to handle the nerve during surgery. Most of the time we don't handle the nerve. We can go close to it, avoiding injury to the nerve. You can see the recurrent laryngeal nerve that is protected and saved. If that is done, the chances of loss of voice is very, very minimal. And even if it is there, it will be a transient neuropraxia which will recover by itself. Now we have this technique of what is called as neuromonitoring. So what you do is we use special endotracheal tubes which will have an electrode which will be at the level of the vocal cord. And once you stimulate the recurrent laryngeal nerve, or the area where you feel the nerve is, then you will get certain impulse. The nerve gets stimulated, the vocal cord contracts, and you can record you can see the contraction on the screen, which tells you about the nerve integrity, as well as at the end of the procedure whether your nerve is still functional or not. This is very helpful when we are doing recurrent goiters, second time, third time surgeries, and when there is a retrosternal extension of the goiters. And one more problem they say with thyroid surgeries is hypocalcemia, and that happens because you are not protecting the parathyroid. See, the parathyroid should be like this at the end of the surgery. You can see the parathyroids, just the parathyroid alone is left behind. Thyroid is removed. So not only you have to leave the parathyroid, but you should see that the parathyroid is vascular at the end of the procedure. We usually see that, and if the parathyroid is not vascular, we will auto-transplant it into the forearm. Now, for thyroid surgery, you also have daycare surgeries, so that a patient can go home on the same day. Within 24 hours, they can go home. And there is also the endoscopic procedure. Generally, any endoscopic procedure, the aim is to have minimal or no pain, early discharge, early return to work, and then it should be minimally invasive. With obviously, there should not be any scar. But in thyroid, the picture is slightly different. For example, this patient, you can see there is a nodule in the neck. Now, that will be removed from the axilla. You can see the incision will be in the axilla and over the breast or the nipple area. And then to reach this, you have to make a track from here up to the position of the thyroid, and then you remove it. Similarly, for the other lobe, you have to go from this side. So from both lobes, you will have to dissect this entire area instead of this small area in the neck. So even though it is endoscopic, what you will see here is that there will be more dissection, prolonged surgery, induration and continuation over the chest walls, which will persist for weeks, and it results in more pain and longer hospital stay. Unlike the usual laparoscopic adrenalectomy or laparoscopic cholecystectomy, where the procedure is very useful because the access wound is very small, whereas here the access wound, even the entry point is small, the rest of the dissection is much larger than the routine thyroidectomy. With the routine thyroidectomy, it's a daycare surgery. There is minimal pain, back to work very early, scar in neck can be minimized, there is no induration or contusion over the chest wall, and there are no contraindications, whereas endoscopic procedure, carcinomas, advanced carcinomas are all contraindicated. So to conclude, I would say that thyroid diseases are very common in women. Hypothyroidism, hyperthyroidism, and goiters are the three common issues. When you treat a patient with hypothyroidism, for example, they come to you for a dental procedure, see that the TSH is normal. If the TSH is normal, you can go ahead with your procedure. Similarly, when a patient with hyperthyroidism comes to you for a dental procedure, see that the T4 or FT4, free T4 is normal. If they are normal, you can undergo the patient can undergo your procedure. Then most of the goiters that we see in clinical practice in women are benign, but they need to be evaluated to rule out malignancy. The evaluation is done with FNAC and ultrasound. They have diagnostic role, and some patients will undergo nuclear scanning and some CT scanning. PET scanning is not routinely used in the diagnosis. Most of the thyroid nodules, which are benign and kept on follow-up, will eventually grow in size. And safe thyroidectomy in expert hands is the definitive management for thyroid goiters. And over the years, our experience we have shared in many of the publications in national and international journals, especially from Amrita while I was working in Amrita, and also in Lucknow, Sanjay Gandhi, subsequently at Nellore, and now at BMH. We have been able to publish many of these, our experience and our data on thyroid and thyroid diseases in various journals, and also contributed to book chapters. And recently we have also published book for patient education, addressing their common concerns about thyroid diseases, hypothyroidism, and other issues. So thank you very much for this opportunity. I thank IDA Malabar office bearers, Dr. Samira, and also the president, Dr. Shaju, Dr. Navjeevan Raj, and the WDC state office bearers for this opportunity to discuss about common thyroid problems in women. Thank you once again.
Thank you, sir. It is a very elaborate session. So we have few doubts. Sir, again,
Samir, the audio is little bit low.
Hello, am I audible, sir?
It's better now.
Okay, sir. Sir, a word for those who joined late. എപ്പോഴാണ് നമ്മൾ ബ്ലഡ് ടെസ്റ്റ് ചെയ്യുന്നത് എന്നുള്ളതാണ്, അതായത് empty stomach ആണോ അതോ any time during the day? Only for those who joined late, sir. അവർക്ക് വേണ്ടി ഒന്നും കൂടെ സർ ഒന്ന് പറയാമോ എന്നുള്ളതാണ്.
Yes, that is a common issue, the common doubt, when it should be done. And not only that, the confusion is even contributed by the lab people. Some of the lab people advise patients to come like this, do like this, avoid that, don't take medicine on that particular day. So many instructions are given by the lab people. Actually, if the patient does not have any dyslipidemia, then the patient can give sample at any point of time, any time of the day. The patient need not be fasting. They can take their thyroxine on the day of blood estimation. But if the patient is having dyslipidemia, the lipemic serum will interfere with the assay. So that's why we ask them to come fasting.
Okay, sir. Thank you, sir. Sir, അതുപോലെ എന്തൊക്കെ ഫുഡാണ് നമ്മൾ അവോയ്ഡ് ചെയ്യേണ്ടത്, അല്ലെങ്കിൽ എന്തൊക്കെ ഫുഡാണ് ഇൻടേക്ക് നമ്മൾ കൂട്ടേണ്ടത്?
Now, see, goitrogens are an important group of vegetables. There are certain important substances, vegetables like cabbages, cauliflowers, they all are goitrogens. They can interfere with the thyroid hormones. So generally we tell them to avoid that. And also it's important to see that the patient are not iodine deficient. So, but that is not an important issue for us here, because most of our patients and our studies from Amrita on the general population have shown that our patients are all iodine sufficient. And also there are some genetic factors involved, genetic element involved. You can see many patients, mother and daughter having hypothyroidism, or mother and other family members, or mother and a particular lady and their sisters having hypothyroidism. So this is a common thing. Some genetic aspects are also there. And as I said earlier, autoimmunity is also there. That also has a genetic linkage.
Okay, sir. Sir, apart from that, any lifestyle modifications required?
Generally, not much for a thyroid disease. But of course, if you are a hypothyroid, if you're a hyperthyroid patient, the drug dosage might be affected. Maybe you require more dosage for a patient who is sedentary and overweight versus a person who is active, and because the dosages are dependent on the body weight.
Okay, sir. So for a person who is already active, a person hyperthyroidism ഉണ്ടെന്നുള്ളത് നമ്മൾ എങ്ങനെ മനസ്സിലാക്കും സർ? ജനറലി സ്വെറ്റിംഗ് അങ്ങനത്തെ ഇഷ്യൂസ് ഒക്കെ ഉണ്ടെന്നുണ്ടെങ്കിൽ അത് ഹൈപ്പർതൈറോയിഡിക് സ്റ്റേറ്റ് ആണെന്നുള്ളത് ജസ്റ്റ് ബ്ലഡ് ടെസ്റ്റ് കൊണ്ട് മാത്രം നമുക്ക് കൺഫേം ചെയ്യാൻ പറ്റുമോ സർ?
No, as I said earlier, in the slide when I showed about hyperthyroidism, I said it's not one single symptom. It is a combination of symptoms which will make you suspicious. For example, the patient is having weight loss, and along with that, the patient is having sweating, the patient is having amenorrhea, the patient is having diarrhea. A combination of these symptoms, plus when you assess, you find that there are fine tremors, you find that there is ophthalmopathy, you find that there is a mild increase in thyroid, you find that the patient is having increased pulse rate. So a combination of this, along with that, when you do thyroid function, as I showed you in that different combinations that is possible, you have a patient, the hyperthyroid patient will have a high T4, high levels of T4 or FT4, obviously because the thyroid gland is hyperfunctioning. And as a consequence of that, the pituitary gland will be suppressed. So TSH should be undetectable or low. So you will find that the blood TSH is very low, T4 is high, plus you have a combination of symptoms and signs. If you don't see that the symptoms and signs and the thyroid function are not matching, you have to repeat the test and see. You have to order the test from another reliable lab.
Okay, sir. So we have a doubt. Is tapioca a goitrogen? Tapioca.
Yes, it is included in that.
Okay. So another doubt is, what about the thyroid levels in children? Is it different in adults?
Yes, it is different in adults. I will just put the screen sharing for you. Just 1 second. On the screen sharing, I will show you that. Actually, it's very, very different. And it's very difficult to remember the values in these patients. It may be difficult. So what you have to do is you have to keep a reference with you to see the levels, because in children the normal levels are different than that of adults. I'll show you that. I actually purposefully skipped congenital hypothyroidism because that itself is a big topic. You can see the reference ranges are different. For 1 to 3 days, 4 to 7 days, 1 to 2 weeks, everything is different. You have to keep these ranges with you to remember.
So
Then the age in weeks.
Hello, sir.
Hello?
Screen share vannitilla, sir. Screen sharing vannitilla.
Okay, sorry. But it is showing that I am sharing the screen.
Yeah.
I think it's the desktop. The folder is shown.
Pardon?
The
Folder is shown, not your PPT.
Okay. Anyway, I don't know what is wrong here, but the reference ranges are different. For example, if it is a 24-week-old child, then the reference range of TSH can be 0.2 to 30. Whereas when it becomes 30 weeks, it is 0.2 to 20. So as I said, it is very difficult to remember these ranges. You should have a reference range with you. Then only you can cross-check with that. It's not the same as adults.
Okay, sir. So regarding the same, there's another doubt connected to it. What about the symptoms? Are they also different?
Symptoms, see, as I showed initially in the slides, the neonate, there will be, the mother usually complains that the child is not feeding. Then there is a prolongation of the physiological jaundice. The child is lethargic, inactive, and constipated. abdomen is distended, and you will see the umbilical hernia persisting. So these are some of the symptoms which you will see in the child.
Okay, sir. Sir, is there any link with vitamin D deficiency, sir?
Not obviously, it is not there. You cannot connect directly vitamin D and hypothyroidism, but many of these patients have coexisting vitamin D deficiency. But that in general, most of our patients are vitamin D deficient. 80% of our patients are vitamin D deficient. You can connect anything with vitamin D, including COVID-19 and so many other things you can connect with vitamin D.
Okay, sir. So, any doubts from the panelists? Panel doubt undo? Any further doubt from the audience?
Hello.
Yes, madam. Hello.
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 Hello. Parnolo, madam. Kunyamma, ma'am.
Ma'am's audio is muted.
Ma'am. Ma'am, audio muted, ma'am. Unmute cheyanam.
Hello.
Yes, ma'am. Ippa kelkkunnundu. Parnolu, ma'am.
Intake at any time it can be stopped. If 50 milligram നമ്മൾ thyroxine എടുക്കുകയാണെങ്കിൽ at any time with evaluation അത് stop ചെയ്യാൻ പറ്റുമോ?
Madam, generally what we do is when a patient is on thyroxine, like for example, you said 50 microgram. 50 microgram എടുക്കുന്ന patient thyroxine എടുക്കുന്നുണ്ടെങ്കിൽ, we will do the thyroid function test. If the TSH is say normal means between 1 to 3, I think 1 to 4, it is normal. That means the patient is euthyroid with that dose of thyroxine. You cannot stop it. But if the TSH is low, like it is less than 0.3, that means, or less than 0.5, that means that particular dose is slightly high for the patient. In that case, what we will do is we will decrease it by 25 and see. After 6 weeks, we will again assess. So after 6 weeks, after decreasing it to 25, if the TSH goes up to 5 or 6, that means it is not appropriate time to stop it. But if after decrease to 25, again the TSH remains low, less than 1, then what we do is we will stop and see for 4 weeks and again reassess. Suppose it becomes abnormal, that means the patient requires a minimum of 25. But if it remains normal, that means the patient does not require thyroxine. So it is, we have to titrate and see. We cannot abruptly stop.
Then what about papaya? Papaya effect, is there any papaya like tapioca? Because my fruit is papaya.
Papaya is okay, madam. You can enjoy papaya. There is no problem. As long as you are taking thyroxine, you can enjoy papaya.
Okay, ma'am.
Thank you. A nice topic. Nicely elaborated. Thank you. Thank you.
Thank you, madam.
Thank you, ma'am. Any further doubt from the panel?
Doubt and total thyroidectomy കഴിഞ്ഞാൽ എത്ര നാള് നമ്മൾ മെഡിസിൻ എടുക്കണം, തൈറോക്സിൻ എടുക്കണം?
If total thyroidectomy has been done, then it has to be lifelong thyroxine supplementation, because you don't have any functional thyroid tissue in your body. But if you find that you are able to stop thyroxine, or your thyroid function remains normal after a so-called total thyroidectomy, it means that it was not total thyroidectomy. It was something less than that. Or some thyroid we have seen cases where mediastinal goiter is still there after total thyroidectomy. So that mediastinal goiter was producing thyroxine. So the patient had normal thyroid function even after a total thyroidectomy. So if the patient is having a normal thyroid function after a so-called total thyroidectomy, that means it was not total. There is functioning thyroid tissue there. Otherwise, if it is a total thyroidectomy, they will have to take thyroxine lifelong.
Okay. So I hope we come to the end of the doubt session. For felicitations, I would like to invite our WDC chairperson for the IDA Kerala State, Dr. Millie James. Ma'am, kindly unmute.
Hi, Sam.
Hello, ma'am.
Thank you so much. Good evening, Dr. Pradeep, sir. And Good evening to the President of IDA Malabar, Dr. Shaju. I believe our State Secretary is also there, present in this webinar. Dr. Deepu. Hi. Hi, sir. Good evening.
Yeah, good evening.
Hello.
Good evening. And our WDC reps, Dr. Samira and Dr. Shebi. Thank you very much for organizing such a wonderful webinar, but I'm extremely sorry I couldn't attend this because we are having a webinar in our branch also at the same time by Dr. Joby Peter. So I had to miss most of the webinar portions, but still I know I have been in and out of this webinar too, just to see how it is going. And I could see that it is a very well narrated, a brilliant topic, and it was very well explained. Thank you so much, Dr. Pradeep, for the wonderful session. And I wish you all the best and hope we can have another session very soon. Thank you so much. And thank you, IDEA Malabar. And thank you, State Office. Thank you.
Thank you, ma'am. Over to Dr. Shebi Shaju for delivering the vote of thanks.
Good evening, all.
Good evening, ma'am.
Respected IDA Kerala State Secretary Dr. Deepu, IDA Malabar President Dr. Shaju Mandori, Secretary Dr. Raj, and our faculty Dr. P.V. Pradeep sir, then our WDC State Representative Dr. Millie and Priya, and our representatives and our past CDH representative Dr. Danya Murlidharan. Welcome all. Today, of course, today's class was thyroid, and it was very useful since it is very common in females. Hypothyroidism, goiter, and so on, combination of symptoms makes it more complicated. But Dr. Pradeep's well-crafted presentation makes it more simplified so that we can deal with then some patients. Suspecting thyroid dysfunction comes to us. Thank you, sir. Thank you very much, sir. Now, let me thank our Honorable Secretary, Dr. Deepu, our Branch Secretary, Dr. Raj, our President, Dr. Shaju, WDC State Representatives, Dr. Millie and Priya, and doctors, WDC representatives from various branches. Thank you all. And our PD representative, Dr. Unikrishna, thank you. Once again, my sincere thanks to all the participants who made this webinar a well-crowded one. Once again, thanking all and one who attended today's webinar on thyroid. Thank you all.
Thank you, ma'am. So this is IDA Malabar signing off. We'll be back with yet another webinar. Thank you, everyone. Have a great evening. Thank you, Pradeep sir. Thank you, everyone.